to the Western Cape now, that province, of course, remaining the epicenter of our COVID-19 outbreak. If you look at key areas that are highlighted in the Western Cape that have the highest number of COVID-19 patients, they would include Tygerberg and Khayelitsha with over 4,000, and Klipfontein and the southern and eastern districts, and then Mitchell's Plain on that graphic there. And of course in the center of that is Tygerberg Hospital in Cape Town, the biggest hospital in that province, currently in the epicenter of the coronavirus in the country. The massive institutions had to deal with a number of issues in the last few months of lockdown, including health workers who've succumbed to the pandemic. Ventilators are a cornerstone of treatment for those very ill with COVID-19. But the Tygerberg Hospital says it's having some success with a process called high-flow nasal oxygen. Dr. Usha Lala is the head of the intensive care unit at Tygerberg Hospital. She's agreed to speak to us very briefly via Skype. Dr. Lala, good evening to you. Thank you so much for your time on the Pulse this evening. What's the difference between this treatment that you're using and being put on a ventilator? What's the difference between them?
Hi, thanks. So the ventilator requires basically a tube down the throat, and the ventilator then takes over the work of the lungs. High flow, on the other hand, is a very purely oxygen delivery system, and it doesn't require any sort of equipment that needs to go down the throat or anything invasive. So it looks very much like a normal oxygen cannula, two little tubes that go through the nose. The patients are wide awake, they're eating, they're talking, they're fully awake. They can converse with their families and the people around them, unlike the normal intubation and ventilation where we sedate them, or what people call a medically induced coma, in order to take over the treatment of the work of the lungs. The high flow basically allows the patient to be fully awake, breathing on their own, communicating, and being part of the whole experience of the ICU, which makes a massive difference when they're quite sick.
As I understand the reports from other countries, it seems that most people who are put onto a ventilator, the process that you described, actually don't make it. Many of them actually do pass away. What's the success rate with this treatment? What's the difference?
Yeah, so I think that was one of the reasons why we very quickly realized our previous ventilation strategies were not going to work. I think one of the international journals quoted a 97% mortality on mechanical ventilation, and that was certainly our experience in the first 6. So we started off ventilating the patients as we used to, as what the international community suggested, but we found that the high flow, the next 7 patients we started, and 6 of those 7 patients survived. Patients that would have been intubated and most likely have died as well, which prompted us to have a mind shift as to, to attempt high flow first before being intubated. And certainly in Tygerberg Hospital, we had considerable success thus far.
Are you recommending that other hospitals in the Western Cape and the country, perhaps around the world, follow what you're doing?
I do think so. I do think high flow should be definitely considered as an option. There are going to be those patients that downright need intubation from the outset, and there are those patients that do fail high flow. It's certainly something that you need to think about initially, especially those awake patients that are not that sick. It's certainly not the panacea of this COVID-19, which is a terrible, horrible disease, I'm not going to lie, but it definitely has its benefits for many reasons.
And then does it require less resources? Obviously it doesn't require a ventilator, right? But I would imagine a ventilator, the process you described, the medically induced coma, that person would need to be in an intensive care unit. They'll need round-the-clock care, probably one person devoted to them at all times. Is it actually easier on the hospital and on the staff to use this process?
It is much easier on the staff. The patients are awake, so a lot of those nursing care that you've mentioned will certainly take time and effort and numbers in terms of staffing. So these patients are awake and can do many of the things on their own. It can also be used in wards as long. I think the important part to realize that these patients still are very sick. So as long as the patients are under suitable medical supervision and patients trained with high flow, it can certainly be used out of the ICU environment, which is extremely important, especially in South Africa and resource-limited countries where ICU access is limited by what we have.
And Dr. Lala, you'll know better than I that I think the emergency hospital, the field hospital at the Cape Town International Convention Centre has been opened. Patients are there now. Is your unit full? Are you finding that you're at the load of the number of patients you can treat?
Yeah, no, we actually definitely, we're being bombarded with patients. As you know, we are the epicenter. Khayelitsha, as you mentioned just now, Khayelitsha is the epicenter as well. We are managing to cope quite well, but we're certainly being worked hard. And we predict that in the future, the numbers are definitely going to increase. And we're definitely increasing or trying to increase our capacity to manage these patients.
And in the middle of this, of course, as we had the resumption of the sale of alcohol last week as we went to level 3, and this means that society sort of changes from where it was. People are moving around, there are more cars moving around, more car accidents. At the same time, people are drinking more. I presume that's had an impact too.
No, it has a massive impact. It's put a lot of strain on our trauma units and obviously our surgery, the nursing staff, the equipment, the ventilators, and obviously our ICU beds as well. I think crime has gone up by 70%, and certainly we've seen that the trauma-related emergencies in our trauma unit has increased exponentially, which I think is the same picture around the country.
Dr. Lala, I realize it's not your job necessarily to make policy, but I imagine you would have a view. Do you think that it was a mistake to allow alcohol to be sold again, or do you think that's something other authorities should be looking at?
I do think that alcohol has made an impact in terms of our resources, where they should be banned again. I'm not going to say.
No, sure, I get it. You're in charge of an intensive care unit. You have more than enough on your plate.
Exactly.
I do want to ask you, before we let you go and save lives again, you've also been testing a robot that's doing rounds in the hospital. What's that robot doing?
So it was thanks to the university who donated the robot, and so it's been quite it's been quite helpful. So it was initially used for, or the aim was to use it to where doctors get sick, because ICU doctors are very few and far between. If they for some reason can't do it, we will be able to access the robot to use for the patients. But one of the big things that it has been used and is currently being used is obviously the visitors aren't allowed into our ICUs or hospital at the moment, and it gives us an interface with them to speak to their families, to make contact with the outside world, and currently that's its major role in our unit at the moment, which is a massive thing for all these sick patients in ICU.
I can imagine. Dr. Lala, I really do appreciate the time. Thank you so much for the work that you do and that you and your team are doing during this time, and just to, generally speaking, saving lives there. Dr. Lala is the head of the intensive care unit at the Tygerberg Hospital, right in the middle of the COVID-19 pandemic, right in the epicenter there. Well, coming up, more details from that briefing with the Higher Education, Mr. Bladen Zamunda. If you've got a relative